A few years ago, a patient of mine, I'll call him Robert, because that wasn't his real name, came into my clinic for what he thought was a strange, forgettable afternoon. He'd been at his desk, reaching for his coffee cup, when his right hand simply didn't listen to him. The cup slipped. For about 4 minutes, the right side of his mouth felt strange, like it had been numbed at the dentist. He tried to say, "I'm fine," to his coworker, and the words came out slurred. Then, just as suddenly as it started, it stopped. By the time he got home that evening, he felt completely normal. So he did what most people do. He shrugged it off. He figured he was tired. He told himself he'd mention it to his doctor next time. 9 days later, Robert had a major stroke. It left him with weakness in his right arm that took a year of therapy to partly recover. Here is the hardest thing I have to tell you as a physician. Robert's body had already warned him 9 days early. He just didn't know how to read the warning. My name is Doctor, and for XC years I have practiced medicine with a focus on evidence-based prevention, the kind of medicine that tries to catch trouble before it becomes tragedy. I'm not here today to frighten you. I'm here because I've sat with too many families in hospital waiting rooms who've said the same haunting sentence, "If only we had known what to look for." You can know what to look for. That's what the next few minutes are for. 2. Introduction to the topic. Let's start with something important, and I want to be precise about it, because precision matters in medicine. A stroke does not usually arrive with a dramatic, unmistakable movie-style warning exactly the day before. What often does happen, and this is backed by real research, not folklore, is that the body sends smaller, quieter signals in the hours, days, or sometimes weeks leading up to a major stroke. These signals have a name. They can be an early symptom of narrowing blood vessels, or, most importantly, something called a transient ischemic attack, a TIA, often nicknamed a mini-stroke. Let's define our terms simply, because medical language can be a wall between doctors and patients, and I want to tear that wall down today. A stroke happens when blood flow to part of the brain is suddenly cut off, or a blood vessel in the brain bursts. Brain cells need a constant supply of oxygen and glucose carried by blood. When that supply stops, brain cells begin to die within minutes. That's why doctors say, time is brain. Every minute of delay costs real brain tissue. A TIA, or transient ischemic attack, is like a stroke's dress rehearsal. It happens when a blood clot temporarily blocks blood flow to the brain, but then the blockage clears on its own, usually within minutes, before it causes permanent damage. The symptoms look exactly like a stroke. The difference is that they go away, often within an hour, sometimes up to 24 hours. Here is why you should care, even if you feel perfectly healthy right now. Up to 1 in 3 people who have a TIA will go on to have a full stroke, and much of that risk is concentrated in the first 48 hours to a few days afterward. Robert's 4 minutes of numbness and slurred speech was very likely a TIA. His brain gave him a preview of the danger, and because he didn't recognize it, he lost his chance to prevent what came next. This is not a rare, obscure topic. Stroke remains one of the leading causes of death and the leading cause of long-term adult disability worldwide. And a meaningful fraction of major strokes are preceded by exactly this kind of warning sign. That means some strokes, not all, but some, are genuinely preventable if we simply recognize the early message the body is sending. 3. Medical explanation. Let me walk you through what is actually happening inside the body, using language that doesn't require a medical degree to follow. Think of your brain's blood vessels as a city's plumbing system. Blood flows through highways, large arteries, and side streets, small arteries and capillaries, delivering oxygen and nutrients to every neighborhood, every part of your brain. Now imagine debris building up inside those pipes over years. Fatty deposits, cholesterol, calcium. Doctors call this atherosclerosis, a hardening and narrowing of the arteries. It's a slow process, often silent, building for decades before it ever causes a symptom. There are two broad categories of stroke, and understanding both helps you understand the warning signs. Ischemic stroke, about 87% of strokes, happens when a blood clot blocks an artery supplying the brain, like debris finally clogging a pipe completely, or a piece of that debris breaking off and traveling downstream to jam a smaller pipe. This is the type most closely linked to TIAs, because a TIA is essentially a temporary, self-clearing version of the same event. Hemorrhagic stroke, about 13% of strokes, happens when a blood vessel in or around the brain ruptures and bleeds, most commonly because of long-term high blood pressure, weakening the vessel wall, like an old garden hose that finally splits under pressure. This type is less likely to give a preview warning like a TIA does, but it has its own risk factors we'll discuss. Now, why does a TIA happen in the days before a major stroke? Several possible mechanisms exist. A blood clot forming on a roughened, plaque-lined artery wall, often in the neck's carotid artery, can send small fragments, tiny clots, upstream into the brain. One fragment causes a brief blockage that clears, ATIA. The underlying unstable plaque remains, ready to send a larger, more damaging clot days later. Irregular heart rhythms, especially a condition called atrial fibrillation, allow blood to pool and clot inside the heart's upper chambers. Small clots can break free intermittently, each one causing brief symptoms before the big one travels to a critical part of the brain. Narrowing in a major artery can create intermittent low blood flow, especially when blood pressure dips, during dehydration, standing up quickly, or even sleep, briefly starving a brain region of oxygen. The risk factors that set the stage for all of this are ones you've likely heard before, but I want to reframe them not as a scolding list, but as the actual, physical levers that change your risk. High blood pressure is the single largest modifiable risk factor for stroke. Chronically elevated pressure damages artery walls, accelerating both clot formation and vessel rupture. Atrial fibrillation dramatically increases clot risk in the heart. Diabetes damages blood vessels throughout the body, including the brains. High cholesterol feeds the atherosclerotic plaque-building process. Smoking injures blood vessel linings and makes blood more prone to clotting. Obesity and physical inactivity contribute to nearly every risk factor above. Age, family history, and certain genetic factors raise baseline risk, though they don't determine destiny. Excess alcohol use raises blood pressure and stroke risk. None of this is meant to make you feel like a ticking clock. It's meant to help you understand. Your risk is not random. It is built slowly by biology you can influence. 4. Symptoms and warning signs. This is the heart of what I want you to walk away remembering today. The single best tool I can give you is an acronym that has saved countless lives because it's simple enough to remember under stress. FAST. F. Face drooping. Ask the person to smile. Does one side droop or feel numb? A. Arm weakness. Ask them to raise both arms. Does one arm drift downward? S. Speech difficulty. Ask them to repeat a simple sentence. Is the speech slurred, strange, or hard to produce? T. Time to call emergency services. If you see any of these signs, even if they resolve, call emergency services immediately. Note the time symptoms started. This matters enormously for treatment decisions. Beyond fast other warning signs, the ones that so often show up in the hours or days before a major stroke include sudden numbness or weakness in the face, arm, or leg, especially on one side of the body. Sudden confusion or trouble understanding speech. Sudden trouble seeing in one or both eyes. Sudden trouble walking, dizziness, loss of balance, or lack of coordination. A sudden severe headache with no known cause, sometimes described as the worst headache of my life. Here is the critical point I most want to land. If any of these symptoms appear and then go away on their own, that is not reassurance. That is a warning shot. A resolved symptom is not a false alarm. In medicine, we consider a TIA a true emergency, precisely because it so often precedes a bigger event. The days following a TIA, particularly the first 48 hours, carry the highest risk of a completed stroke. When should you seek care? Immediately. Not in the morning. Not if it happens again. The moment any fast symptom appears, even if it fades in minutes, it deserves an emergency-level response, meaning a call to emergency services or an immediate trip to an emergency department. I understand the instinct to not want to make a fuss, to not want to be dramatic, to hope it was nothing. I have met many patients who share that instinct, and I understand it as deeply human. But this is one of the few areas in medicine where hesitation has an outsized cost, because effective treatments for stroke are dramatically time-limited. 5. Diagnosis and medical evaluation. When someone arrives at the hospital with possible stroke symptoms, here is what typically happens, explained without unnecessary jargon. First, doctors perform a rapid neurological examination, testing strength, coordination, speech, vision, and sensation, often using a standardized scoring tool that helps quantify severity and track changes over time. Next, brain imaging is essential, almost always starting with a CT scan, a specialized fast X-ray that creates cross-sectional images of the brain. This helps distinguish quickly between an ischemic stroke, blockage, and a hemorrhagic stroke, bleeding, a distinction that changes treatment entirely. In many cases, an MRI follows, which is more sensitive for detecting smaller or earlier areas of brain injury. Doctors will also look for the why, because understanding the cause shapes prevention. Blood tests check cholesterol, blood sugar, clotting function, and signs of infection or inflammation. An ECG, electrocardiogram, and sometimes longer heart rhythm monitoring checks for atrial fibrillation or other irregular rhythms. Carotid ultrasound examines the large neck arteries for narrowing or plaque. Echocardiogram looks at the heart structure for clots or sources of embolism. If someone has had TIA-like symptoms that resolved, doctors take this every bit as seriously as an ongoing stroke, because the evaluation is the same, and the goal is to identify and treat the underlying cause before a bigger event occurs. This is sometimes done urgently in a specialized TIA clinic or during a short hospital admission for rapid workup. And this urgency exists precisely because we know how narrow the window can be. 6. Treatment and management. Treatment depends heavily on stroke type and timing, and I want to emphasize upfront. Every decision here should be made by a treating physician who knows your specific situation, your scans, your labs, and your history. What I'm describing is the general landscape, not personal medical advice. For ischemic stroke, if a patient arrives within a defined early window from symptom onset, doctors may use a clot-dissolving medication, a clot buster, delivered through the bloodstream to restore blood flow. In select cases, particularly with blockages of larger arteries, a mechanical procedure can physically remove the clot using a thin catheter threaded through the blood vessels, a technique that has transformed outcomes for many patients when performed promptly. For hemorrhagic stroke, treatment instead focuses on controlling bleeding, managing blood pressure carefully, and sometimes surgical intervention to relieve pressure on the brain or repair the source of bleeding. After the acute phase, or after a TIA, long-term management usually includes some combination of blood pressure control, often the single most impactful long-term intervention, cholesterol-lowering medications, commonly statins, to stabilize arterial plaque, antiplatelet medications, such as aspirin or similar drugs, to reduce clot formation, or anticoagulant medications for patients with atrial fibrillation, blood sugar management for those with diabetes, carotid artery procedures in select patients with significant narrowing rehabilitation, physical, occupational, and speech therapy for patients recovering from stroke-related deficits, often beginning within days of the event, because early rehabilitation improves outcomes. I want to underscore something here. The right treatment plan looks different for every patient. Two people with seemingly similar symptoms can need completely different management based on their imaging, their heart rhythm, their other health conditions, and their personal risk-benefit balance. This is why self-diagnosing or self-treating based on a speech like this one is never appropriate. My goal today is to help you recognize when to seek care, not to replace the individualized judgment of the physicians who will actually examine you. 7. Prevention and healthy habits. Now, the empowering part. Because so much of stroke risk is genuinely modifiable, prevention is not a vague wellness slogan. It is measurable, evidence-backed risk reduction. Know and manage your blood pressure. Get it checked regularly. If you're on medication for it, take it consistently, not just when you feel high blood pressure, because it usually causes no symptoms at all until it causes damage. Move your body regularly. Even moderate activity, brisk walking most days of the week, measurably reduces stroke risk over time. Eat with your arteries in mind. A diet rich in vegetables, fruits, whole grains, lean proteins, and healthy fats, with reduced sodium and processed food, supports healthy blood vessels and blood pressure. If you smoke, quitting is the single most powerful thing you can do for your vascular health. The benefit begins within weeks of quitting and continues to grow for years. Limit alcohol to moderate levels at most. Manage diabetes and cholesterol with the same seriousness as blood pressure, working with your physician on target numbers specific to you. Know your personal and family history and share it with your doctor. It changes how aggressively certain risk factors should be managed. Learn fast and teach it to your family. This single piece of knowledge, recognizing facial drooping, arm weakness, and speech trouble, and calling emergency services immediately, is one of the most powerful, low-cost prevention tools that exists because it turns a possible catastrophe into a treatable emergency. Never dismiss a resolved symptom as nothing. If you or someone near you experiences even a brief episode of these symptoms, treat it as the medical emergency it is and seek immediate evaluation, regardless of how quickly it seemed to pass. 8. Common myths and misconceptions. Let me clear up a few things I hear often in my practice. Myth: strokes only happen to elderly people. Reality: while risk rises with age, strokes can and do occur in younger adults, including in their 30s and 40s, particularly with risk factors like uncontrolled blood pressure, certain heart conditions, or clotting disorders. Myth: if the symptoms went away, it wasn't serious. Reality: this is precisely backwards. Resolved symptoms consistent with FAST often represent a TIA, one of the strongest known predictors of an impending major stroke, particularly in the following days. Myth: there's nothing you can do once symptoms start, you just have to wait it out. Reality: modern stroke treatment is dramatically time-sensitive, and effective interventions exist for many patients, but only if care is sought immediately. Myth: only severe headaches signal stroke. Reality: many strokes, especially ischemic ones, cause no headache at all. Weakness, numbness, speech changes, and vision changes are far more common presenting signs. Myth: stroke is purely a matter of bad luck or genetics. Reality: genetics and age matter, but the large majority of stroke risk relates to modifiable factors like blood pressure, smoking, diabetes, cholesterol, and lifestyle. Myth: you definitely know if you are having a stroke. Reality: symptoms can be subtle: mild tingling, slight word-finding trouble, brief unsteadiness, and are easy to explain away, which is exactly why public awareness of FAST matters so much. If I could leave you with one personal message, it's this. I don't want you to leave here today anxious, scanning your body for symptoms, afraid of every headache or moment of clumsiness. That is not the goal of medicine, and it's not the goal of this speech. Fear is not a sustainable motivator, and it isn't necessary here. Knowledge is enough. What I want instead is for you to feel equipped. I want you to know that your body often does communicate before something serious happens, and that learning its language, fast, unexplained neurological symptoms, the seriousness of anything that resolves on its own, puts real power in your hands. I want you to have the confidence to act decisively if you ever see these signs in yourself or in someone you love, without hesitation, without embarrassment, without waiting to see if it happens again. Robert, the patient I told you about at the start, is now several years out from his stroke. He's shared his story with his own family specifically so that they would recognize the warning signs he missed. That's the spirit I want to leave with you today. Not fear, but readiness. A stroke rarely announces itself with fanfare. Often it whispers first, a few minutes of numbness, a flicker of slurred speech, a hand that doesn't quite cooperate, and then, if we don't listen, it returns to make its point permanently. The single most important takeaway I can give you is this. Any sudden neurological symptom, facial drooping, arm weakness, speech difficulty, deserves an immediate emergency response, whether it lasts 5 minutes or 5 hours. Learn fast, teach it to the people you love, and never mistake a symptom's disappearance for its unimportance. You cannot control every risk factor life hands you, but you can control whether you recognize the warning and whether you act on it. That single choice, to call for help the moment something feels wrong, has, in my career, made the difference between a full recovery and a permanent loss. I hope you never need this information, but I hope, even more, that if the day ever comes, you'll remember it. Thank you.